Hello and welcome, everyone. My name is Matt Shepard, and I'll be your moderator for today's webinar, Medicare for People Living with ALS During a Public Health Emergency and Beyond. Today's webinar is brought to you by Team Gleason and will be presented today by Center for Medicare Advocacy Associate Directors Kathy Holt and David Lipschitz. A little bit about our two organizations. The Center for Medicare Advocacy is a nonpartisan, nonprofit organization which, since its founding in 1986, has worked to obtain fair access to Medicare and quality health care for older people and people with disabilities through education, training, analytical research, advocacy, and legal assistance. The center is staffed by attorneys, advocates, a nurse, and technical experts, all working for systemic change based on our daily experiences with the problems of real Medicare beneficiaries. Team Gleason's mission is to help provide individuals with neuromuscular diseases or injuries with leading-edge technology, equipment, and services to create a global conversation about ALS to ultimately find solutions and an end to that disease, and to raise public awareness toward ALS by providing and documenting extraordinary life adventures for individuals with muscular diseases or injuries. We thank Team Gleason for their support in getting this important information out in these unpredictable times. Now, we definitely have a full program today, as is always the case, and I'm sure that we'll have some questions, but I do have to take a couple moments of time to do a little bit of housekeeping here, even though I suspect that everyone in attendance is a little more familiar with these sorts of presentations than they were a month or so ago. If you can hear me, use the information in the email you received after registering to successfully log into our webinar, and you've either dialed in by phone or you've got good working speakers on your computer, either of which is great. Audio quality will, of course, be at the whim of our hardware and our internet connections. So if you are using computer audio, be aware of that, and be aware that if you do have issues, you can always dial in by phone using the number that was provided on your confirmation email, which is also in the audio tab on the control panel that should appear probably at the right of your screen. A couple more things about that control panel, although again, I'm sure many of you are familiar with this. A couple key features for today are some of the buttons on the little tab at the left side of the panel. The little orange arrow will let you hide that panel so it's not in your way. The little square will let you watch our presentation in full screen view. And then there's a little picture of a hand, my favorite. It's used to indicate you have a question. For the bulk of the presentation, our attendees will be muted, but when we open it up for questions at the end, you could use that little icon to indicate you have a question, and I can unmute you. Don't worry though, if, as sometimes happens, the audio is not cooperating or you get shy, we can always type questions into the questions section of the control panel, and I'll do my best to pass those on to our presenters. Finally, everyone should have received a copy of today's slides at the email address that you used to register, but if for some reason those didn't make it, those are available in the control panel in the handouts section. You can just click on them and download them. Thank you all again for attending, and I will now hand things over to Center for Medicare Advocacy Associate Director Kathy Holt to get us started. Kathy.
Thank you, Matt. Thank you, everyone, for joining us and for sharing your time today. In the spirit of full disclosure, I want you to know that I'm honored to be a member of the Team Gleason Board of Directors. We are a dynamic, diverse board made up of individuals with deep expertise in issues that are important to the ALS community. We also have a strong commitment to the vision of Steve Gleason and the tireless, talented staff of Team Gleason to raise the quality of life bar for people living with ALS and to leverage Steve's natural curiosity and leadership to someday live in a world without ALS. But for today, I'm here to speak with you about insurance, health insurance, and our expertise, Medicare. From my home to yours, we'll review a big picture of Medicare. Then we'll turn to my two goals for you today. First, to learn more about programs that help save millions of Medicare beneficiaries money on their out-of-pocket Medicare expenses. And second, to learn techniques that will help you more confidently make the best informed choices about your Medicare and healthcare. We are recording this program so it can be shared and viewed or reviewed on demand, but information changes and exceptions in the rules abound. So I'll caution you to reconfirm what may apply to you. After my time with you, about halfway through our program, David will share information about how COVID-19 is creating opportunities and challenges to getting health care during the public health emergency. Then we'll open it up for questions and discussions. So let's revisit from the beginning about when you can get Medicare. When you or a spouse have paid Medicare taxes that meet the threshold criteria to qualify for Medicare insurance, you have an ALS diagnosis which meets presumptive eligibility criteria for the Social Security Disability Insurance Program, and you have met a 5-month waiting period, not including a partial month, beginning from the Social Security determined date of onset. We did have a question that came in prior to the webinar addressing HR, the House Resolution number 1407 that was introduced by Representative Seth Moulton, currently has 237 co-sponsors and is called the ALS Disability Insurance Access Act, introduced last year. This would eliminate that 5-month waiting period so that as soon as someone qualified for Social Security disability, they would be able to get Medicare and get their Social Security benefits started. So stay tuned, that is a work in progress. When you can choose or change how you get Medicare. So when you're first eligible for Medicare, obviously, then annually during the Medicare annual coordinated election period, and other times during a special enrollment period. So you will have multiple opportunities throughout the time that you're on Medicare to change how you opt to get Medicare, usually at least once a year. So just looking basically at what Medicare is and how it works. Medicare is a federal program for health insurance since 1965. People usually qualify based on paying into Social Security, not based on their income, unlike Medicaid, also known as Title 19 of the Social Security Act, which is based on income. Medicare covers people who are age 65 and older, certain people with disabilities, and people with end-stage renal disease. The benefits cover hospital, skilled nursing facility, home health, doctors, durable medical equipment, prosthetics, orthotics, hospice, prescription medication, and some preventive services and vaccines. People can get their Medicare through either traditional Medicare or a private Medicare Advantage plan. Medicare Advantage plans must cover at least as much services as traditional Medicare and follow the same coverage rules. Medicare is an insurance model. It covers some of the cost of some health care. So when there is care that is reasonable and necessary for an illness or injury, to diagnose, treat, or for rehabilitation or maintenance of a condition, there is also some limited preventive coverage, and there are premiums, coinsurance, and deductibles associated with this model, which we know as Medicare. So looking at an overview of Medicare, there are 4 parts of Medicare. Part A and Part B are traditional Medicare. Those are essentially Part A, hospital or inpatient insurance, and Part B, medical insurance, also usually outpatient insurance. One can add a supplemental policy, like something called a MEDIGAP plan, which I'll talk about, Medicare Savings Program, or employer military coverage to help supplement what Medicare doesn't pay for. Medicare Part C is a Medicare Advantage program offered by private insurance companies. And there are 2 products there. One is a Medicare Advantage plan without prescription drug coverage, although most people will opt for a Medicare Advantage plan that has Part D drug coverage included within it. And then there is Part D Medicare, prescription drug program. Private insurance companies offer this standalone prescription drug plan. Typically, this is matched up with someone who opts for traditional Medicare insurance, the Part A and Part B of Medicare people often will get a standalone Part D for their prescriptions. All parts of Medicare are overseen by the Centers for Medicare and Medicaid Services, both the private and the public parts of Medicare. So when you are choosing how you get your Medicare benefits, you have to select from one of two options, either Medicare A and B, the original or traditional Medicare, or through a private Medicare Advantage plan. Most people who choose original Medicare, again, will add a supplement to help them pay for the deductibles and coinsurance, and a Part D plan to help pay for those prescription drugs. Most people who choose a Medicare Advantage plan opt for, as I mentioned, a Medicare prescription drug plan. Importantly, again, as I had mentioned earlier, all Medicare Advantage plans must provide the same coverage as provided by original Medicare A and B. So before you determine how you get your Medicare and what Medicare option is best for you, either traditional Medicare or the private Medicare Advantage, you'd want to ask these three questions. Can I get assistance in my state to pay for Medicare? Can I get a Medicare supplement plan in my state and at an affordable cost? Or do I have other insurance to pay for out-of-pocket costs? And then using the information from those questions 1 and 2, you'll add it to the other information to consider 3. Which Medicare option offers the best coverage and cost opportunities for me at this time? So let's address each of these 3 questions. Can I get assistance in my state to pay for Medicare? The Medicare Savings Program assists in paying for the costs of Medicare. There are currently about, well, my statistics may be a little bit old, but currently about 8.5 million people access the Medicare Savings Program to help to pay for the costs of Medicare. How do I know if I qualify for that program? Medicare Savings Programs are, again, state programs to help pay for Medicare premiums, deductibles, coinsurance, and copayment. There are 4 kinds of Medicare savings programs, and each are based on a person's income and resources. Income and resource requirements or assets vary by state. Generally, income typically will include wages, interest, Social Security, pension, other, for example, rental income, minimum distributions out of an IRA. Resource or assets that are typically included are money in checking and savings accounts, stocks and bonds, and resources and assets that are typically not included. So there are the home, a car, burial plot, burial expenses, furniture, household items. I'm going to introduce you to a document that is a really helpful document. The National Council on Aging Organizations maintains a 5-page state-by-state Medicare Savings Program guide, and I've got a link to it here. I'm going to walk you through 3 out of those 5 pages, or at least partially from the guide, so I can share better the information with you. So very busy slide, but and I wish I had one of those pointers where I could show you where to look. But if you look at the column that says the financial eligibility on the side there, it says qualified Medicare beneficiary. The monthly income is outlined there. So this happens to be 100% of the federal poverty level. And so you can get a sense of what your monthly income is and if you might qualify for this program. The Qualified Medicare Beneficiary Program is one of the 4 types of Medicare savings programs. And the benefits that are covered, and which you can see on the far right of the chart, it covers the deductibles, the co-payments, the monthly premiums, and coinsurance. So essentially, if you qualify for the Qualified Medicare Beneficiary Medicare Savings Program, it will cover all of the cost sharing or the coinsurance, co-payments, deductibles, and premiums that are required by Medicare. And then the second program that you see down below, the Specified Low-Income Medicare Beneficiary Program, this is a little bit higher monthly income. So while the first program was at or below 100% of federal poverty level, then the second program is between 120 and 120% of federal poverty level. And those numbers are outlined there. The $1,276 for an individual for monthly income. And what this program does is it pays the Part B monthly premiums, which are currently $144.60. And here are the other two programs. For a qualifying individual, this again raises the qualifying amount that someone would have, so between 121 and 135% of poverty level. Again, it covers the Part B premiums. And then qualified disabled working individuals. This is a kind of a really narrow for people who qualify, but they return to work and exceed the limit. So just wanted you to be aware, this is part of this program. So these are the federal guidelines, but what I want to turn to next is showing how each state kind of looks at this very differently. So here is an example from about 20 states. And if we look at this example, you'll see under the asset column that there are any number of states. And again, I'm only showing you here about 20 states, but there are a number of states that have absolutely no asset limit. That means you can have all kinds of assets if you live in that state. And they are looking purely at your monthly income. And then you'll see, like Alabama, they use the federal guidelines, which are what is in that chart that we just went through above. So 100% of federal poverty level or lower to get the benefit that covers all of the cost sharing of Medicare plus premiums. And then we look down, for instance, Connecticut, the District of Columbia, Illinois, Indiana, Maine. Those states offer higher levels of income that you can have. So for instance, if you live in Washington, D.C., there are no asset limits, and you can earn essentially up to about $38,000 a year and still qualify for the benefit that will pay for all of your Medicare cost sharing. Each state is different, so I encourage you to go to the link. Sorry, I didn't want to show every state, but I did want you to see that there are possibilities of coverage. We find that this program is very underused. So if it's possible that you might qualify for this, that would make a big difference on how you end up deciding which Medicare choice you're going to make in the long run, whether or not you will want to choose traditional Medicare or a Medicare Advantage plan. So the good news is the screening and the application process for the Medicare Savings Program is pretty easy. And if you've been through, which you would have in order to get Social Security, Medicare under age 65, that application process is horrendously long and difficult. This screening application process is relatively easy in many states. It's just a 2-page application. You can contact your state health insurance program, which is a wealth of resources for free personalized assistance to review your qualifications and to apply for the Medicare Savings Program. And there's the link where you can find the state health insurance program for your state. Okay, so let's look at the second question, which is, can I get a Medicare supplement plan in my state and at an affordable cost? Or do I have other insurance to pay for my out-of-pocket costs? So you've looked at whether or not you qualify for Medicare Savings Program. That'll give you a lot of information. The next question is, can you get a supplement, or do you already have other insurance? So the Medicare supplement plans, also known as MEDIGAP plans, they are to pay for those gaps in traditional Medicare, those deductibles, the coinsurance, and the excess. Medigap pays if Medicare pays. So let me give you an example. I get a speech generating device. Medicare would pay 80%. If I had a Medigap, most plans would pay the remaining 20%. So it's not different coverage. It's coverage that once Medicare pays and you have a Medigap, that Medigap will kick in the deductibles of coinsurance, the excess charges, depending on which plan you choose. So you have to have Medicare Parts A and B to buy a Medigap plan. But generally, you cannot have a Medigap plan and have a Medicare Advantage plan. If you're under age 65, there are limited Medigap availability and affordability in many states. There's no federal guarantee issue of a Medigap plan. Over age 65 and over in most states, you have to sign up within the first 6 months of Part B coverage in order for it to be guaranteed issue. Interestingly enough, if you are on Medicare and you're under the age of 65 and you turn 65, you get that 6 months of guaranteed issue, that window of opportunity to get into a Medigap plan. In all states except for 3, federal law requires insurers to sell standardized Medigap plans. All plans in a given category, for example, all Plan A's, all Plan B's, have identical benefits. Ironically, they decided they were going to name plans by letters, and there are parts to Medicare, so it does get a little complicated. But a standardized plan, plans that have identical benefits, mean that insurance companies can offer the exact same benefits, but with different monthly premiums. There's no benefit to selecting a plan with a higher premium in the same plan category. So for instance, I'll give you some examples here. The Medigap Plan A covers hospital coinsurance and Part B 20% coinsurance, but it doesn't cover hospital or Part B deductibles or skilled nursing facility copays. The Medigap Plan G covers all coinsurance, all copays and deductibles, but not the Part B deductible. So an individual who had a Medigap Plan G would pay $198 out of pocket toward any of their Part B expenses, and everything else would be covered. And you can find the chart that outlines all the plan coverages for Medigaps in your 2020 Medicare and You handbook. And here's a link to that at page 70. This is just to illustrate that there are 31 states that require Medigap insurers to sell at least one policy to people under 65 with disabilities. The others don't require a sale of a Medigap policy, but only 2 states currently do not have insurance companies that will offer a Medigap plan. So it's important to just kind of look through what some of these Medigap plans have pre-existing condition limitations, which of course would cause a problem, but there are others that are just enormously expensive. So it's good to look at what's out there, what the opportunities are in order to try to get a Medigap plan to cover the gaps that Medicare doesn't cover. So how do you find out about those Medigap plans? Again, call the state health insurance program, and I've given the link again. Then the great thing that we've seen recently is that the SHIPs have access to a new automated Medigap tool that's currently only available to SHIP personnel. And that is available if you call them to get assistance. They'll be able to look at all the Medigap options in your state and give you information on what that looks like. The other question is, do you have other insurance that would cover those out-of-pocket costs? So perhaps you had an employer and that you left that employment, and they have some secondary insurance that will cover those gaps. the Veterans Administration, VA coverage, TRICARE for life for people who had been active military or are a family member, Medicaid, other types of insurance that would help to cover those out-of-pocket costs. So that kind of addresses those first two questions, which really are about what does the financial landscape look like when you're trying to determine whether to choose a Medicare Advantage plan or a Medicare plan, a traditional Medicare plan. So now we're going to look at which Medicare option, either traditional Medicare or Medicare plan, offers the best coverage or cost opportunities for me. So in traditional Medicare, first, in addition to traditional Medicare, you have to determine which Medicare Advantage plans are available in your area. And so you can go to the Medicare Plan Finder, and again, here is the link to the Medicare Plan Finder. And if you don't have a My Medicare account, that's also a good thing to have, because then you can enter information about medications and other information, and it will retain that information for you. You can also get your Medicare summary notices and other information through a My Medicare account. But the Medicare Plan Finder will help you to get more information. If you would prefer, again, you can contact the state health insurance company. So when you're looking at Medicare Advantage plans, there are a couple of different models that are considered kind of the most common models of Medicare Advantage plans. There are the Health Maintenance Organization Medicare Advantage plans, and they're usually the least expensive of the Medicare Advantage plans, but they have the most obstacles. For example, you have to see a primary care provider to get a referral to see a specialist, and there's typically no out-of-network coverage. A preferred provider organization, these Medicare Advantage plans are typically more expensive than HMOs, but they have fewer obstacles. For example, you don't need a referral to see a specialist. And there is usually some out-of-network coverage, but usually paid at a lower percentage. So when counseling people about their Medicare options, I often say you don't have a crystal ball about your healthcare needs. You don't know if you'll be in an accident or you'll have a heart attack, but you should think about what that might look like. When you look into your crystal ball, you found you have ALS. So you can already answer a lot of questions on this checklist. Who are your preferred doctors, specialists, therapists, home health agencies, nutritionists, hospitals, DME suppliers, clinics? Contact those offices and ask what Medicare Advantage plans they belong to. And be specific as to plan names. These names are so ridiculous. There's, something like the Aetna 100 Gold HMO Premium option. I mean, they could have 10 different names attached to them. So you can't just say, I have Aetna, or do you cover Aetna? It has to be the more specificity that you can give. Having looked at the plan finder and found out which plans serve your area, you can have that list. And when you talk to those providers, you can ask them that question. Do they belong to those plans? Do they intend to stay with those plans or renew their contracts? Now, they're not going to guarantee you that things might not change, or that the Medicare Advantage plan might change, might not renew a contract, but they could give you a sense of stability. What problems, if any, have they had obtaining prior authorizations from the plan? Have their decisions about treatment been questioned or overruled by the plans? And even if they won't tell you or recommend any other plans over others, can they please at least tell you what plans they recommend you not choose because they've had difficulties with them? So there are pros and cons to Medicare Advantage plans. The cons are, again, that Medicare Advantage plans have limited, potentially unstable networks of providers and many more layers of prior authorization requirements through utilization review committees, medical directors of plans, a lot of other folks in addition to your treating providers. There are pros to Medicare Advantage plans. If you can't get help paying for the out-of-pocket expenses. Medicare Advantage plans have a maximum annual out-of-pocket costs. And in 2020, it's $6,700 in network, $10,000 if you go to out-of-net, if you have one of those preferred provider organizations and you go to an out-of-network provider. So there are caps in Medicare Advantage plan. Well, unfortunately, at this time, there are no caps in traditional Medicare. It only allows for limited consideration of the value of the Medicare plan extra services. And what I mean by that is don't join a Medicare Advantage plan because they offer you $100 of dental or a grab bar or a few rides. Look at the big ticket medical coverage that you need. There are Medicare Advantage plans are allowed to offer extras, but often their value is not worthy of what you need in your medical care. So here's one strategy. You might think about what you're going to need over the next year. So for instance, if you're getting ready to get a customized power mobility device, then talk to the DME suppliers, the wheelchair suppliers, about coverage and cost choices that would be most helpful to you. Here's a tip about getting services from a Medicare Advantage plan. Medicare Advantage plans, again, I can't stress this enough, must provide all of the Medicare Part A and B services. There is a Medicare plan regulation that states that there is a requirement for Medicare Advantage plans to provide all the services. And that regulation states that a Medicare Advantage organization offering a Medicare Advantage plan must provide enrollees in that plan with the basic benefits. And you can see down below in yellow, basic benefits are all items and services for which benefits are available under Parts A and B of Medicare. Don't be distracted by the other than hospice care, because at this point, most Medicare Advantage plans are not offering hospice care. You have to elect to go back to traditional Medicare for those. But my point on this slide is, let me give you an example. If your home health agency won't give you all the aid services that your doctor orders, it is the legal responsibility of the Medicare Advantage plan to find an agency to provide those covered services. So hold their feet to the fire. You may have the agency may say, oh, we can't do that, but it's, then you go to the plan itself. Just a few quick thoughts here before I turn it over to David. I recently prepared some practical tips about getting durable medical equipment, prosthetics, orthotics, and supplies. And I want you to have this as a resource because it's information about how you best obtain durable medical equipment generally, and also getting the orders, getting it set up, getting it straightened out, making sure that everything is ready to go. And then here's a checklist of questions that you would want to ask to a supplier. It's always good to double check whether a supplier has the item that maybe the Medicare website says that a supplier says they carry. And it's always good to double check to make sure that's true. Just looking at the longevity of the Medicare supplier, how long have they been in business? Are you able to get me what I need from my prescriber? How well are you going to work with my prescriber? Do you accept Medicare assignment? So this is, again, a really important point about suppliers who are enrolled in Medicare, but they don't take assignment. Well, what does that mean? That means that they can charge you more, and there's no limit on what they can charge you. That means that they can charge an extra cost for delivery, setup, and training. If you go with an assigned, Medicare assigned supplier, they're going to be able to deliver, set up, and train as part of the cost, and it's a lot easier. It could be difficult to find sometimes an assigned supplier. So just double check on that, be aware of that. And more questions, again, just as a resource for when you are seeking out durable medical equipment, prosthetics, orthotics, and supplies. And looking for the big red flags through the Better Business Bureau online reviews if you're not familiar with the supplier and you haven't worked with them before. So in summary, when you have answered those questions for yourself, can I get assistance in my state to pay for Medicare through a Medicare savings program? Can I get a Medicare supplement plan, or do I have other insurance to pay for out-of-pocket costs? And then looking at the pros and cons of Medicare Advantage, a private Medicare Advantage plan, or traditional Medicare, which in essence allows you to go to any provider that Medicare covers. And it doesn't have, except for, of course, some durable medical equipment that requires prior authorization. There's no prior authorization that's required in traditional Medicare. You have significant healthcare needs as someone living with ALS, and you should have the confidence that you make the best choice about your Medicare options for both you and your healthcare. So, David, I'm gonna send this over to you.
Thank you, Kathy. And I'll wait for the control of the slides over here.
That should be at you now, David.
It is me. Thank you kindly. Thank you, Matt. Thank you, Kathy. And thanks to all of you who have tuned in today. Kathy walked through some of the basics concerning Medicare coverage and enrollment. Now we're going to shift gears, and I'm going to talk a bit about how some of these things have changed in response to the current COVID-19 pandemic. These are indeed remarkable times. We are in the midst of a public health emergency, and it is unclear when it will be over. I'm going to walk through some of the recent policy changes that the Medicare program has decided to authorize as a result of the current crisis, starting with a broad overview and then hit some highlights and then touch on some of the systemic issues, some of the things that advocates are concerned about and paying attention to. At the outset, Kathy gave a warning about rule changes and how things can change in the Medicare program, so it's wise to keep on checking back. That is particularly true with respect to all these COVID rule changes. This stuff is literally changing daily. There are differing interpretations of what some of these rule changes mean, and in some sense, we're all kind of making it up as we go along. We do at the Center for Medicare Advocacy have an advocate's guide that covers many of these changes that was more or less current as of a week ago. And we are currently updating and should be updated by the end of the week or early next week. And a link to it is provided later on in the slides. There has been a lot of debate about how the federal government has responded to the coronavirus or COVID-19 crisis. Today, we're going to talk about some of the things that the government has done with respect to Medicare in response to this crisis. So far, Congress has passed 4 COVID-19 related bills. Most of these bills have been focused on helping people retain jobs, on propping up the economy, although there have been some health-related provisions in these bills. Congress is currently working, pardon me, on another large COVID-related bill, although it's unclear at this point what will be in it and when it might pass, although it's not likely to pass within the next couple weeks. There's not apparently a sense of urgency to do more. At the end of this presentation, we'll briefly talk about what many advocates think still need to be done. Most of the changes to the Medicare program have been administrative. That means the Centers for Medicare and Medicaid Services, or CMS, that administers the Medicare program, has issued regulations and guidance. Most of the Medicare-related changes that we're going to discuss have been made retroactive to March 1st and will last until the public health emergency related to the COVID-19 crisis is lifted, whenever that may be. There's some discretion on the part of the Secretary of Health and Human Services to extend that temporarily, but suffice it to say at this point, it's unclear how long these changes will be in effect. Most of these changes have been accomplished by waiving or temporarily excusing or suspending or not enforcing a number of rules that usually apply in the Medicare program. The broadest rule changes have surrounded the increased use of telehealth services. And, if you think about it, of course, this makes a lot of sense. In an effort to try to minimize the spread of the virus to both individuals and those who are providing them with healthcare services, a lot of services that Medicare covers that usually require people to be face-to-face with their providers can now be done remotely via telehealth. We'll talk more about that in a moment. There's also been an expanded recruitment of providers, recognizing that there's a great need for people to actually provide the care, and there's been loosening of restrictions like allowing licensed providers to practice outside of their state that they normally practice in. A lot of flexibilities have been given to hospitals, skilled nursing facilities, and other facilities, including where such services can be provided, and things like waivers of certain notices that such facilities are usually required to give to people. And also, over the long term, of some concern to advocates, as again we'll touch on at the end, there has been a suspension of many requirements that usually apply to providers, doctors, hospitals, et cetera, regarding reporting issues and general oversight by the Medicare program, including quality and other measures. So again, the biggest change that has occurred in the Medicare program in response to the COVID crisis has been an exponential expansion of the use of telehealth services. And this covers a range of providers and services in a range of different types of settings. Providers that can engage in telehealth include doctors, nurse practitioners, clinical psychologists, and licensed clinical social workers. Just recently, within the last week, CMS authorized physical, speech, and occupational therapists to provide covered telehealth services. The type of services include routine visits, mental health counseling, preventive health screenings for cancer, and other illnesses. Now, when looking at the Medicare rules about what telehealth is and how it is defined, it usually requires the combination of both some type of audio and video or chat function that enable a provider and a patient to both talk with one another and interact visually. So most telehealth services in general are limited to the ability or limited to using both audio and video function. However, there is a range of things that can be covered for people who only have access, for example, to an audio phone. Not everyone has a smartphone. Some people just have the ability to talk rather than see folks over the phone. But this keeps changing too. And more services are being allowed to be covered by Medicare for people who have just audio capacities. And this has included audio phone capacities to include many behavioral health and patient education services. Certain evaluation and management services can also be done through audio only. Also, within the scope of services that can be provided to people remotely, things that fall under the category of telehealth are usually the broadest. But there are also what are known as virtual check-ins and e-visits, which are usually more limited, briefer communications, shorter time with healthcare practitioners, and communications through patient portals and things like that, which also are coverable. So the bottom line here is, if you need or are in need of health services that can be provided over the phone, contact your provider and work with that provider. He, she, they now have more leeway to provide services remotely and get paid to do so during the current crisis. A couple of notes about telehealth. Note that cost sharing for such services can be charged just as cost sharing services can be charged for in-person visits. However, the providers that are rendering such services can reduce or waive such cost sharing at their discretion. There's been issuances by the Department of Health and Human Services Office of Inspector General informing providers that contrary to usual practice, they will not be subject to sanctions, or they will not be punished if they reduce or waive cost sharing, because usually there are concerns about inappropriately steering folks and giving them a break for cost sharing if they usually have to charge it. So it's unclear to us how this is going to play out, whether or not providers are going to by and large charge for telehealth services, but know that they do have the ability to charge for telehealth the same rates that you would usually pay generally for inpatient visits, or in-person visits rather, but be aware that you can ask that provider to reduce or waive that cost sharing without that provider being punished for doing so. Another important thing to note with respect to this broadened coverage for telehealth services is, of course, folks who are taking advantage of this fact. Beware of fraud. There is increased concern about telephone scams. And just the Medicare program today issued a warning to be on the lookout for scams such as robocalls that are offering you respiratory masks that the caller will never send, social media posts fraudulently seeking donations for non-existent charities or claiming to give one stimulus funds if you enter your bank account information, and fake testing kits, cures, or immunity pills and offers for protective equipment. Be careful in this environment when a lot of the requirements have been loosened, and there are unscrupulous folks who will take advantage of that. And to the extent that you can, try to protect yourself and your Medicare information. I want to move on to the issue of testing for COVID-19 and treatment. This has been a source of a lot of confusion as of late, in part because there have been grand statements by some about COVID-related treatment being covered without costs for everyone, even those who are currently without insurance. But looking at the actual rules and the guidance that has been issued and what Congress has passed to date, that is not the case so far. Testing generally should be covered for those with Medicare with no cost sharing. And that applies both in the traditional Medicare program, original Medicare, and for folks in a Medicare Advantage plan. That used to be that an order from a physician was required. That's a requirement that CMS waived within the last week or so. So it may be covered, COVID testing may be covered when ordered by any healthcare professional authorized to do so under state law, and the testing itself should not come with cost sharing. The vaccine, when available, will be covered by Part D plans and Medicare Advantage plans that offer prescription drug coverage. But when it comes to treatment, the general rule is that treatment someone receives for COVID-19 can be subject to cost sharing. People can be charged cost sharing for it, just as they can be charged cost sharing for other services. Medicare Advantage plans have the discretion to waive cost sharing for COVID-19 related treatments, but they are not required to do so. Now I'm going to move on to a highlight of some of these waivers of rules in different settings and different services. Starting with hospitals, there has been some loosening of the rules, including where services can be provided. Medicare is allowing extra days in the hospital for patients who would have been discharged but were diagnosed with COVID-19 and had to stay longer under quarantine. The usual requirement that private rooms be charged at a higher rate is waived if that a private room is medically necessary for an individual, including, don't want to try to stop the spread of the disease. Hospitals are able to perform tests for people at home and in other community-based settings, and Hospitals in general have greater flexibility to furnish inpatient services, including routine services outside of the hospital. I think folks, if you might have been watching the news, for example, you've seen tents set up in Central Park in New York City. It's, as a overflow for hospitals. That is permissible as long as certain guidelines are followed. Turning to skilled nursing facilities, have really been at the center of this epidemic. Nursing facility residents tend to be at much higher risk for COVID-19 because they're generally older. They're in a congregate setting with a lot of people together in one place. And many individuals or residents tend to have underlying conditions. And we are seeing many tragedies unfold across the country in skilled nursing facilities. With respect to rules that have been waived surrounding skilled nursing facilities, in Medicare, in order for Medicare to cover a stay in a skilled nursing facility, one of the requirements is that someone must have been an inpatient in a hospital for at least 3 days. That rule has been temporarily waived for people who experience dislocations or are otherwise affected by the COVID-19 crisis, which is pretty broad. Another waiver has to do with how long someone can get a SNF benefits or skilled nursing facility benefits covered by Medicare. Usually there is a limit of up to 100 days covered in a skilled nursing facility per a benefit period. If someone needs skilled care beyond that time as a result of the COVID-19 crisis, then someone can get covered SNF benefits beyond that 100 days. Because the skilled nursing facilities have really been an epicenter of COVID-19. There are facilities where there are a lot of folks who have the virus, facilities where people do not have them. There has been a lot of movement of residents around and so-called cohorting. And there have been a lot of waivers of rules that have allowed facilities to move people, to group people who have the virus versus people who do not have the virus. And for a time, it's led to a lot of confusion and periods of times when families don't know where their loved ones are, in part because a lot of the usual notices that facilities are required to provide to folks who are being moved have been waived. There are rules that apply to both people in the facilities and those who wish to visit them. All visitors have been banned to skilled nursing facilities except for certain compassionate care situations, usually at the end of life. Most oversight has been suspended, and that includes most surveys that are usually done of skilled nursing facilities. Some surveys that are continuing are those that try to measure a facility's ability to stop infections, to perform infection control. But of these inspections that are continuing with respect to infection control, the results so far are still of concern and include a relatively high rate of lack of adequate personal protective equipment and lack of adequate hand washing, which is one of the most important steps people can take to try to prevent the spread of this disease. Fairly recently, the federal government has started to issue guidelines about, or requiring rather, facilities to report to the federal government, to the CDC and others, including the residents themselves and representatives of residents, about whether or not there are folks in a given facility who have tested positive for COVID-19. And that still is a work in progress. Moving on to the home health setting, there have been changes with respect to home health. And again, in each of these settings that we're talking about, a lot of the requirements surrounding the need for a face-to-face, in-person visit have been relaxed so that many services can be provided via telehealth. There has also been a loosening of one of the requirements for access to the home health benefit. And one of the rules for home health, in order to qualify for coverage under Medicare, is that an individual has to be deemed to be homebound, not bedbound, but homebound, which generally is confined to the home, an individual who cannot leave the home without considerable and taxing effort. The Medicare program has not waived that requirement, but it has loosened it somewhat so that to meet the definition can include someone for whom it is medically contraindicated to leave the home due to a confirmed or suspected diagnosis of COVID-19, or if someone has an underlying condition that makes the individual more susceptible to contracting COVID-19. So again, the homebound requirement has been loosened but not waived with respect to Medicare coverage criteria. Medicare has expanded the types of providers that are authorized to order home health services, including physician's assistants, nurse practitioners, and clinical nurse specialists. They are allowed to instigate home health coverage. Moving on to Medicare Advantage, as Kathy outlined in the first half of this presentation, that's one of the options that people have to get their Medicare coverage. They can choose to enroll in a private plan that administers their Medicare benefits. During a disaster or emergency, Medicare Advantage plans are required to do certain things, including the following. Kathy talked about how Medicare Advantage plans, specifically HMOs usually, are restricted as far as the types of providers with whom they contract. During this COVID crisis, Medicare Advantage plans must cover benefits at facilities with which they do not have a contract, but facilities that have participation agreements with Medicare. They have to charge the same cost sharing for in and out of network services. These are requirements that unfortunately not all plans are following or are aware of. We have had to intervene in at least one instance and educate the legal department of one Medicare Advantage plan that they in fact had an obligation under this Code of Federal Regulations provisions to cover benefits at a non-contracted facility. In addition to things that Medicare Advantage plans have to do, there is a long list of things that they may do, things that they can choose to do, things that are in the discretion of the Medicare Advantage plan, as long as they do so in a uniform fashion. In other words, if they choose to relax some of their rules, they have to do it for everyone in the plan. They can't pick and choose for whom they are relaxing certain rules for. Among the things that Medicare Advantage plans can do include they can not use prior authorization requirements. They cannot require you to seek the plan's permission before they cover something. They can waive cost sharing. They do not have to, but they can waive cost sharing for COVID-19 treatments. They can waive prescription refill limits, expand access to telehealth, and they can implement new or expanded benefits as they might relate to people in the current COVID-19 crisis, including things such as meal delivery or medical transportation. There are also certain requirements with respect to the provision of prescription drugs. Under one of the bills that passed Congress, both Medicare Advantage plans that offer prescription drug coverage and Part D plans must cover up to a 90-day supply of a covered drug when a beneficiary asks for it. This is not as open-ended as I think folks originally thought. There are some limitations on this. Such drugs have to, if they are subject to certain requirements by the plan, like step therapy, in other words, also called fail first, if the plan requires you to try one drug before it'll authorize another one, or if there are prior authorization requirements on a certain drug, such requirements have to be already have been met in order for the plan to have to give out this 90-day supply. And there are also further limitations for safety edits, which usually apply to controlled substances such as opioids. Part D plans, including Medicare Advantage plans that offer Part D coverage, have to ensure enrollees have access to covered drugs at out-of-network pharmacies if an enrollee cannot reasonably expected to use one of the pharmacies that the plan contracts with that are in network. Plans can, but don't have to, relax restrictions on mail and home delivery, and pharmacists can authorize emergency refills when the physician prescriber is not available to provide the refill renewal prescriptions. A couple of other quick type service waivers that I want to touch on has to do with ambulance transportation. Usually there are very strict requirements in the Medicare program about origin and destination and where an ambulance has to originate from and go to when it's transporting a Medicare beneficiary. During the current COVID crisis and a public emergency, there are some relaxation of the rules if certain facilities are unavailable, and Medicare may pay for limited non-emergency transport if a physician writes an order stating that such a trip is medically necessary and requires transport by an ambulance. Cost sharing will apply. So if you're in a situation where you need to go by an ambulance and it's a destination that's usually not covered by Medicare, this might be an opportunity to have such a trip covered. You need to work with your doctor in order to establish that such a trip is medically necessary. Kathy earlier walked through some issues related to durable medical equipment. During public health emergencies or other disasters, some rules are waived. In such emergencies, if items are damaged or lost due to a disaster or emergency, in most cases, Medicare will cover the cost of repair or replacement. And in most cases, Medicare will cover the cost of a rental during a repair or replacement. In the current COVID-19 crisis, the Medicare program has said that it is waiving prior authorization. You should check with a Medicare Advantage plan if you are in one, though, and are seeking durable medical equipment. They are not requiring accreditation for newly enrolled suppliers. Remember some of the cautions Kathy had about trying to sort out what suppliers might be better than others. Medicare is covering a broader array of respiratory devices. And if an item is lost, destroyed, damaged, or unattainable or unavailable, the Medicare program is waiving certain requirements that Medicare contractors have to follow, including a face-to-face encounter or a new physician's order or a new necessity documentation. With respect to Medicare appeals, we often find it's the case that a given provider or facility will not always honor what they are obligated to do under the Medicare program. And that includes Medicare Advantage plans and Part D plans. And an individual must appeal in order to obtain coverage or payment for reimbursement for coverage for which they've already paid. In general, during the current crisis, Medicare contractors, the companies that process Medicare claims, Medicare Advantage plans, and Part D plans have all been encouraged to exercise maximum flexibility with respect to appeals. And for example, the COVID crisis by itself can be good cause for filing a late appeal. If folks need to file an appeal and it is not timely, we're encouraging folks to say you are requesting good cause based upon the COVID-19 crisis. A couple of quick words about enrollment. Kathy earlier talked about enrolling in the Medicare program initially when someone's first eligible. There are some folks who become eligible for Medicare but have employer-based insurance coverage that is primary to Medicare. And so some people decline Part B when it is first offered. Those folks usually, if their employer is big enough and certain other rules are met, will have an opportunity to use a special enrollment period to pick up Part B when they lose or drop that employer-based coverage. Its Social Security Administration is the entity that usually processes those requests. And of course, Social Security offices have been closed to the public recently, even though they are still providing some services over the phone. Usually when someone's trying to exercise one of these special enrollment periods for Part B, there are a lot of forms that are required, including like proof of employment, proof that you had employer-based health insurance coverage. There have been some relaxation of some of these rules. We refer you to our website and some of the stuff that we've put there that are related to Social Security. Also, Social Security has its own, the Social Security Administration has an own portion of its website that covers COVID-related issues. We refer you to them. Just recently, in the last few days, the Medicare program has stated that if people were unable to enroll in Part A or Part B in a timely manner when they had a right to do so because Social Security was closed or because you're unable to get through, you didn't know where to go, had trouble getting your requests processed, there is a process called equitable relief that might help you exercise your right if you have missed certain timeframes or certain deadlines. There is a deadline to file such a request with Social Security by June 17th. So, a little over a month from now. If you find yourself in a situation, or if you're unsure, if you're in a situation where you might have missed an opportunity to enroll in Part B or Part A, and you weren't being prevented from doing so, this might be something worth exploring with Social Security, with the State Health Insurance Assistance Program, and others that might be able to assist. Somewhat similarly, there have recently been some rule changes announced with respect to enrollment in Medicare Advantage and Part D plans. A special enrollment period, or SEP, has just been announced for people who are eligible for but were unable to make an election because enrollment election because they were affected by the COVID-19 pandemic. This only applies, however, to folks who had a valid election period at the time of the COVID crisis and did not make an election during that time period. So, in other words, because of everything going on, with the COVID-19 crisis, you might have had a right to make a plan change or enroll in a certain plan, but you missed that opportunity. So if you had a valid election period, but that opportunity has passed, you might be able to exercise a right to a special enrollment period. Now, all the language that has been released about it says it's available from the start of the incident period for 4 full months afterwards. However, none of the material has said when the start of the incident period was, so it's a little unclear what the actual time frame is. Note, however, that no proof is required to show why you missed the deadline. In other words, you should be taken at your word. Finally, in closing, just want to touch on a few systemic issues. From an advocate standpoint, what are some of the global or broader issues that give us some concern? I mentioned earlier that Congress has passed a few bills, and there have been some health-related things in there. However, individuals who advocate on behalf of older adults and individuals with disabilities are quick to point out that a lot more could be done in order to assist people with getting through the current COVID-19 crisis. And that includes closing coverage gaps, going further with enrollment issues in those last 2 slides we went over with respect to enrolling in A, B, or Medicare Advantage or Part D. The easing of application and eligibility for the low-income programs that Kathy talked about earlier, and all the variance between the states. Some states don't look at assets, some do. And other means that, for example, ensuring that the caregivers of people, older adults and individuals with disabilities, are adequately taken care of, whether it's, through compensation or additional protective equipment or availability of such, are all among the things that Congress can and should do in the views of many advocates when it comes to adequately addressing the needs of individuals. And if you're more interested in finding out what some of those issues are, or at least what advocates are saying about them, I refer you to a couple of coalitions which we belong, Leadership Council of Aging Organizations and the Consortium for Citizens with Disabilities. Their websites include a plethora of information and recent requests that these respective coalitions have made to Congress. Some of the rule waivers have been beneficial for beneficiaries, whether it's the waiver of that 3-day prior inpatient hospitalization requirement for skilled nursing facility services, or the extension of the period of time someone can have skilled nursing facility benefits. And we would love to see some of those made permanent. But there have been a whole lot of other rule changes, including rolling back consumer protections, rolling back oversight of providers to ensure that things are being services are being provided with requisite quality and without fraud, waste, or abuse, that we fear might not be reinstated. There are already calls among various different industries to retain some of the flexibilities that they have been given. Some of us are concerned what that might mean when we approach more or less normal situation again. Also, it's been pretty evident that the current COVID-19 crisis has both highlighted and exacerbated a lot of the underlying problems and barriers to care that people have experienced and experienced prior to the current crisis. That includes lack of home health aides under the home health benefit, premature discharges from home health and skilled nursing facilities, and particularly in skilled nursing facilities, staffing shortages, the lack of minimum staffing ratios, watered down infection control standards, and oversight. So I finally point you to a couple of resources that can provide you hopefully with a lot more information about COVID-19, a portion of our website that we try to update daily with materials from CMS and elsewhere, and the Advocate's Guide I referred to earlier that focuses on beneficiary-related changes pursuant to the current COVID crisis. With that, I will stop talking and see if we have any questions that Kathy and I might be able to address.
Thanks, David. We do have a couple questions written in, sort of specific DME questions, and we have one brave raised hand. And you know me, I'm always going to try for the live question. So let's see if Joe can unmute. Joe, you have your hand up. Can you unmute, and can we hear you if you do? Let's give him just a second. All right, looks like Joe is staying muted for the moment. Oh, there we go.
Yes, hello. I don't
Hello,
really
Joe.
have any questions, but I just saw that I was unmuted and thought I'd say hello.
Oh, hello. I'm sorry.
Hello.
I saw your hand up there. Well, I'm glad to have you here today,
Hey, Joe.
Okay, guys, take care.
Thank you.
Thanks.
Thank you.
You too.
Let's try Mary. Mary, go ahead. Perhaps a similar situation to Joe. Mary, are you there? All right. We can go to our typed in questions. And as I mentioned, these are DME questions and fairly specific, and I think from the supplier side. But let's give it a shot. The more general of the two questions is, could you expand upon the role, if any, of DME professionals, assistive technology professionals, to participate in complex rehab technology assessments with a PT and/or OT via telehealth? Whew, that's a lot.
I can take a stab at it, and then David can take a stab at it from the telehealth standpoint. I would say that it's a fairly narrow clinical question, but I would I'm going to punt it over to you, David, because I think it really is the telehealth part of the question now that I'm reflecting on it.
Yeah, and I'm looking at our guide right now online where we list a lot of the kind of exceptions and waivers that the Medicare program has engaged in, and a lot of them do provide site-specific or provider-specific type of waivers. I do not recall, or I'm not seeing anything specifically with respect to durable medical equipment evaluation relating to assistive technology. That might be something that the Medicare program just has not addressed yet, or we're unaware of it. So, Kathy, I guess in a situation like this, it might be best to check with the DMAC, the Durable Medical Equipment Administrative Contractor.
Sure. The other suggestion that I always have is the suppliers always know first if something is going to be covered because it's their livelihood. So they will often, particularly in the instance of a complex rehab, it seems to me, David, I could be wrong, but I think for things that have to be measured, like a wheelchair, there's certain things that do require where they're not waiving in person function.
I'm sorry, I just pulled this up. If the questioner, if you go to our website or follow this link to our advocates guide, there is a section currently starting at the bottom of page 16 of our advocates guide that's going to be revised in a few days that talks about national coverage determinations and local coverage determinations. And it does reference what we have found so far with respect to what Kathy was just saying, how some face-to-face encounter requirements for DMEPOS power mobility devices are mandated by statute, and those are not waived, but CMS will not enforce required clinical indications for coverage across respiratory, home anticoagulation management, and infusion pump NCDs, and it has a list of devices. I'm not seeing assistive technology on there, but that's I think the best information we have seen. But there's a lot more on the CMS website that may or may not actually address that specific question.
Thank you both. I'll give you a little break before we hit the next DME question. And I will answer one for Barbara, who asks, is there an email address if we have more situation-specific questions? And I will give you our address of communications@medicareadvocacy.org. That'll come to me, and I can get that to the appropriate people. Now back to you guys. But again, we'll delay before the next DME question. How about an enrollment question? What if a person applied for Part B during her special enrollment period, but the response is delayed by all of this, preventing her from applying for a MEDIGAP policy because she is not yet enrolled in Part B?
Well, I don't think that the MEDIGAP companies are necessarily bound to make up for mistakes that Social Security Administration makes, for example, but I think I would work with the MEDIGAP company to which you're applying or trying to sign up, and that you have, if this is your first time getting Part B, and you're in one of the states, if you're under 65, you're in one of the states that Kathy mentioned that has to have policies sold in the state that to people under 65, that you do have a certain window of time within which to work, and the issue might be just nailing down when the effective date is of Part B. But it can't hurt to work with the MEDIGAP issuer and let them know you are applying and let them know when you applied, so that if and when Social Security ever does process that SEP request, that the effective date of the MEDIGAP will align with when your Part B is effective. It can't really start before then. So I think the best measure is to work with both Social Security and the MEDIGAP issuer in that instance. I don't know, Kathy, if you have anything to add to that.
Yeah, no, I would completely agree. And as David said, while the if it is a guarantee issue, although it sounds like, you know, a special enrollment, maybe if you're coming on for the first time, depending on if you're over 65 or if you're over 65, you would get a guarantee issue in every state as a federal requirement. One would think that the federal part of that would allow you to have that extension of time, but Medigaps have not been mentioned, as David has said, in any of the waivers that I'm aware of.
Thank you both. I'll hit you with that second DME question now. We have a Medicare beneficiary who's had a custom manual wheelchair authorized, but she's currently being held in a SNF, post-acute rehab stay, rather than returning to her assisted living facility due to a massive COVID outbreak. Could we deliver her chair, which is otherwise not covered for delivery to a SNF, while she awaits return to her assisted living facility?
So technically, no, because if someone is in a skilled nursing facility, they are not entitled to Medicare payment for durable medical equipment. That is in the statute. And as David was saying, CMS, the agency, the executive agency that administers Medicare, they can waive certain things, but when it comes to a statutory provision that Congress has determined, it's not waivable. So I would say no, it's not possible to do that if someone is in a SNF. However, there seems to be some leeway that's happening now, and given the circumstances, frankly, I would suggest contacting the individual's representative, congressional representative or senator, to see if in some way they can find an exception to that process, since it was underway and since the reason for the person is still in the skilled nursing facility is due to the public health emergency. David, do you have any other thoughts on that?
No, other than because so many rules have been waived, it can't hurt to try. You know, again, it might be the durable medical equipment administrative contractor that you'd have to deal with, and again, a lot of this is being made up as we go along, and there's always the danger that you can have one contractor saying yes, and then later on they say, well, wait, that shouldn't have been done. But I think given the general environment and with how many rules have been waived, you know, try to contract the contractor, try to get something in writing from them, and see if it is feasible. But like Kathy said, in a normal scenario, the answer would be no. But with so many things going out the window and so little oversight, you know, it's possible that you know, it can be effectuated.
Thank you both again. Kathy, I'm guessing this one's probably for you. I'm a caregiver for an ALS patient and waiting for Radicava infusions at home, and have been told that there's a Part D issue holding this up. Do you know why that might be?
Okay, so yeah, I was trying to get some more information on what's happening with whether or not Radicava will be covered through Medicare, as it is with so many other insurance companies, as a home infusion. I shouldn't have stopped that statement when I was saying it, because it is covered by Medicare. Please don't misunderstand me. Radicava is already covered by Medicare, but it's not covered as a home infusion therapy benefit. So in trying to do some research on this, there are probably so many other people on the phone who are much more savvy as to the answer to this question about when and whether. I know there's an awful lot of people that are advocating to have Medicare cover Radicava as a home infusion benefit. I think personally what's holding it up, and again, I could be way off base on this, but because it is infused either by gravity in the bag, either by gravity or attached to a pump through an infusion bag. I think Medicare has a policy that is limiting home infusion drugs to external infusion pumps. And because of that policy, and because Radicava can be infused by gravity and not necessarily require a pump, I think it's been put into a category that has not yet kind of been approved by Medicare. There is, as of January 1st of 2021, the home infusion therapy nursing services benefit will begin. There have been 3 of the 6 accrediting organizations that have already approved this, and so the process is moving along. Whether or not that's going to include Radicava, I don't think so. But like I said, the National Home Infusion Association, any number of organizations are trying to make it possible. And while we at Medicare Advocacy are not the clinical experts who would be able to kind of lead the charge on having it covered by Medicare, we are certainly supportive and certainly would be, from a policy standpoint, want to see that happen so that people don't have to leave their homes in a crisis or out of a crisis, because it's like so difficult to move about in general when someone has ALS. So I don't know that it's helpful, and I don't know if anybody else on the phone can raise their hand and chime in, because as I said, I know there are a lot of other people who are really watching this very closely.
Thanks, Kathy. Keep an eye out if somebody does want to volunteer. We have a couple enrollment-related questions as well here. Go to Emily's question. My pals still has excellent private insurance. When he signed up for SSDI last week, they signed him up for Medicare, though we requested that he not get it yet. Do we now have to sign up for Part B and supplemental insurance and pay for those, even though we don't actually want them yet? Ultimately, after he has kicked off his work insurance, we'd want the supplemental insurance and not Medicare Advantage. Thank you. He is under 65 and we're in New York, if that helps.
Okay. And I think another question I would ask is the insurance, the good insurance that he has, is that based on someone's active employment? And if he's on SSDI, this sounds like a confusing question, but if he's on SSDI, he's probably not working. So is the insurance through a spouse or a family member? And the question is, how many employees does the employer have? Because that makes a difference as to whether or not Medicare is primary or secondary. And if Medicare is to be primary because he's working for the insurance is through a smaller employer, less than 100 employees in that organization for people who are under 65, then that will make a difference as to if Medicare is primary, he will have to sign up for Medicare within a few months of becoming eligible for it. David, do you want to expand on that?
Yeah, no, other than just to underscore that's exactly right. And another way of saying it is, if that private insurance is even retiree coverage or through a former employer or COBRA or some other means, it is not going to be primary to Medicare unless, as Kathy said, it is based on a spouse or family member's current employment and the number of employees of that employer is at least 100. And there's different ways to reach that number. You know, there's some different technical rules, but it's imperative really to answer those questions in order to determine if you need to sign up for Part B now and exercise or any right you might have to get a Medigap, because this is really a area where that trips up a lot of folks as they transition to Medicare coverage, is not making the assumption that the insurance they have will work the same as it always has, but they're very important distinctions based on whether or not someone is currently active employing, which could allow that insurance to continue to function primary to Medicare versus being secondary.
David and Kathy, Emily expanded on her question and said that his employer, who has thousands of employees, is just leaving him on his private insurance at the moment. And do we have to have Medicare now, or could we ask them to delay it so that the Part B, supplemental, et cetera, is not triggered?
Yeah, that you might want to, thank you for the question. You might want to follow up with us about that, because there are certain rules about what constitutes current active employment. So I do recall we've come across situations in the past where employers will just leave someone on the insurance, but there are certain rules that assess whether or not someone is actively working, as opposed to not working or on certain suspension statuses or something else. So I think we need a few more details and probably a lot more research in order to give you a definitive answer or something approaching a better answer rather than one we can give right now, I think, over the phone.
Yeah,
All right,
I agree with David. I would also be a real cautionary tale that the insurance has to be based on someone's active employment, because we have seen people who have been laid off, people have gotten severance, people have gotten all kinds of where their employers have benevolently extended their insurance only for the person to find out later that because the insurance wasn't based on someone's active employment, that Medicare will not allow them to delay signing up for Medicare. So yeah, we're happy to take a closer look at what that means.
Thank you both. So yeah, Emily, feel free to shoot me an email. That's communications@medicareadvocacy.org, and I'll get that to Kathy and David. Thanks very much. Our other enrollment question, if you guys are ready. I know we're a little over time, but these questions have been in for a while, and I did say we had 2 more. So Brenda asks, or says, her husband was just diagnosed last month with ALS and is still employed, although home now due to the COVID concerns. Due to his physical declines, we aren't sure if he can return back to work. However, if he does, he could then go on short-term disability and on long-term disability after 6 months. So my question is, when should he start the application process for Medicare? He's only 60, so is that a factor as well? After the 6 months of short-term disability is over, he would lose his employer insurance, and we don't want to wait. We want to be proactive if we can. Thank you.
Okay, so he cannot submit an application for Social Security disability until such time as he is not engaged in substantial gainful activity. And social, that's the first threshold criteria that Social Security looks at. You can't like put yourself in the queue and say, okay, I have a presumptive disability because I have a diagnosis of ALS. So that's kind of the I don't know how to say it. It's kind of the what the chicken and an egg thing, right? But if he were to stop working because he has an ALS diagnosis, the day that he stops working, he would qualify for that would be his onset of his disability, and it's a presumptive disability, so there's not a question. You can you can't apply ahead of time. You can get Social Security retroactive up to a year prior to application. So that gives you an opportunity to submit an application and then get coverage previously. You're not going to lose out on coverage, I should say. And while we still do have that 5-month waiting period for Medicare and the actual payment of Social Security benefits from the onset date that is used, that can also Medicare can also be retroactive. I hope that answers the question.
Thank you, Kathy. We have a couple more questions and one live hand. I know we're 4 minutes over, but you know me, I can't resist those hands. Can we try one more live question and see how it works out?
Of course.
All right, Pamela, are you there?
I'm here.
Woohoo, it worked.
Thank you for doing this. It's been extremely informational. I guess I'd like to revisit that 5-month waiting period. That's been in Washington for a while. Do we have any idea as to when that might be a reality, that would be waived for ALS patients?
I don't. I mean, I mentioned the information that we have, that as of the last co-sponsor signed on April 10th. So there are currently 237 co-sponsors. I think this is a priority for ALS organizations, and I think it's being, from an advocacy standpoint, what would need to happen to keep it moving, if you will, especially prior to this next election, which would usher in a new Congress and have to start all over again. So if you're trying to get it done this year, the really important thing is to look at, it's called House Resolution 1407. And if you look it up online, you can see who the co-sponsors, the 237 co-sponsors are. And you know, people far and wide, if they could contact other people who have not yet signed on. And this bill has been introduced in the House. I don't see a companion bill in the Senate, although I do know that there is quite a bit of support in the Senate for this as well. So that the only thing that I can tell you is it needs to have a coordinated effort to keep it going forward.
Kathy, if I could interject,
Please.
a Claire from Team Gleason noted that the session is stalling it moving forward at the moment.
I'm sorry, could you say that again?
That the session is stalling it moving forward.
Yeah. So Claire would know.
So thank you, Pamela. Thank you, Kathy.
Mhm.
Thank you, Claire. Claire, do you want to expound upon that?
Yeah, sorry, I was having some technical issues.
No
Yeah, a lot of
problem.
it is just dealing with timing. COVID couldn't have happened. It's a horrible thing that happens at any time, but things are moving very quickly on the Social Security bills, and we do have a lot of support in the Senate, a lot more than's evident online. So it's really just, it's poor timing in many, many ways. Hopefully we can get this back in order when people get back in DC.
This is David. Just to jump in really quickly, I think it's probably not a surprise to folks that there's a wide chasm of viewpoints in Congress with respect to expanding eligibility and enrollment in programs versus restricting eligibility and expansion of coverage. But I think to increase the chances of a bill like this passing, it would be best to try to find a champion of a bill that is either a chair or ranking member or high up in seniority on a committee of jurisdiction. So like in the House, the Ways and Means or Energy and Commerce, and in the Senate, the Senate Finance Committee. And if a bill has such a champion and that person pushes to have the Congressional Budget Office score the bill so you know how much it's going to cost, that makes it much more likely that it can be slid into a larger bill when different money is being allocated or different changes are being aligned or arranged in different bills that need to pass. It's probably not a bill that would pass on its own, but a much greater likelihood of being tucked into something else.
All right, thank you all. Thanks for the great questions. We are, as noted, well over time now, but it's been a good time. Brenda and a couple others will follow up with us by email. Thank you for that. I want to thank everyone who attended. I want to thank Kathy and David for some incredible and timely info. And of course, Claire and everybody else at Team Gleason for the support and for allowing us to get this information out. Please keep an eye on our webpage, that's medicareadvocacy.org. Look down in the lower right on the front page, you'll see we've got webinars that we're hosting or involved in, I'm pretty sure every week up through June. So check back regularly. Our next webinar will be on Medicare appeals, and it will be presented by two of our advocates, attorneys who have done literally thousands of Medicare appeals. So if you want the scoop on Medicare appeals, that's the webinar for you. Thank you all again, and I will now conclude today's webinar.